Hey guys, as you know, my name is Jessica North, and I'm going to present to you guys my capstone project on sepsis. And you guys already did one survey before we started, and we're going to do it again afterwards, and then we will compare answers and see if you learned anything from my presentation. Um, so the object of my capstone project is to raise awareness of sepsis in the hospital and the hospital systems in the United States, with the focus being searching for the best evidence related to sepsis and determining the impact that that has in hospitals using sepsis screens and sepsis bundles and education for the staff. Screening for sepsis starts the minute the patients walk through the door. For us, that would be in our triage room, and it should continue throughout the length of stay with assessments done with every vital sign and then with any change in patient condition. It's imperative that we as nurses apply evidence-based practice and use our hospital protocols regarding sepsis and use that in our everyday practice. So sepsis affects over 1.6 million Americans daily. I think that was on the survey. um, it doesn't. So 1.6 million Americans are hospitalized. I'm messing myself up here. Sepsis, it's a third leading cause of death in the United States, which is more than prostate cancer, breast cancer, and AIDS combined. I did not know that until I did this research. Sepsis is the #1 cost of hospitalizations, totaling over $20 billion per year. Based on research and guidelines, early recognition and prompt treatment are the key factors to successfully treating and combating sepsis. Early identification and treatment of patients with suspected sepsis, severe sepsis, or sepsis shock may increase survival rate for our patients with sepsis. Screenings are becoming a regular part and standard of care in hospitals across the United States. We already use that. It's in our triage of patients when they first come to the hospital. Sepsis screening tools look for 2 or more positive SIRS, or systemic inflammatory response syndrome. The screen looks like this. If temperature, respiration, febrile temperature, and hypothermic. Respirations greater than 20, heart rate greater than 90, initial white blood cell count won't be on there, or PCO2. If the patient has a confirmed or suspected infection, then you would call a positive sepsis screen. Severe sepsis would be if the patient is also hypotensive. Then that's a emergent situation. You really need to get that patient treated right away. Some other things that you look for with sepsis or septic shock: if the lactate's greater than 4, decreased urinary output, low platelet count, new onset respiratory, cardiac, or central nervous system decline. If any of these categories are positive, you really want to inform the provider immediately with the severe sepsis shock, right away with the SIRS and sepsis, definitely within that first half an hour to get treatment started. My original PCOT question: an emergency department patient with a positive sepsis screen, how does the start of early sepsis bundle, including 2 sets of blood cultures, lactic acid, white blood cell count labs drawn, normal saline or lactated ringers, fluid resuscitation at 30 milliliters per kilogram, and antibiotics started, compared to current standards of care, affect patient outcomes within the recommended 3-hour window for severe sepsis? So the search strategy that I used electronic databases, Medline, 2 different databases on the FSCJ website were searched through using keywords. I used Sepsis Bundle and Emergency Department, and then filtered through that to find articles that were published within the last 5 years that were full text, English language. The purpose, surviving sepsis campaign. It's a pretty cool thing. It's a big international guideline that was put together few years. Actually, I think the first one was 2010. I want to say, but they redo it every so many years to add up-to-date best practice for sepsis. It was developed by a panel of 55 international experts. It's broken into 5 sections with experts in each section working on those areas to come out with community members to come out with the best evidence-based practice for each section. Results include 18 of the best practice statements, 32 strong, 39 weak recommendations, and then those guidelines are intended to be best practice. They're not intended or created to be standard of care. Hospitals are using evidence-based guidelines to create sepsis protocols that include sepsis screening with positive sepsis alert, time 0, which is the start of the sepsis bundle from the time the sepsis bundle is called from the provider at triage. Sepsis bundles with severe sepsis and sepsis shock management. Many hospitals have applied these evidence-based practice already and started implementing these programs that alert nurses and providers at the very first sign of sepsis, like I said, during the triage process. Sepsis screenings are part of the EMR. They're triggered during the triage process. They should start in the ED with the first patient contact. If a patient screens positive, the triage nurse alerts the provider to the positive alert. If the provider agrees, then the sepsis bundle should be implemented. And again, the nurse is looking at that SIRS criteria and then any sign of infection. And you have half an hour really that you really want to tell the provider if that's screening positive. Time 0 again is the triage time when the alert was first deemed positive and the provider made aware. It's also the time the clock starts for the sepsis bundle and sepsis compliance. The nurse should notify the provider of a positive screen within 30 minutes. Once the bundle is ordered by the provider, the nurse should complete the bundle within 1 hour. It's recommended within 3 hours, but best practice is 1 hour. And that bundle includes, again, fluid resuscitation, 30 milliliters per kilogram, blood cultures before antibiotics, broad spectrum antibiotics within 1 hour, white blood cell count, lactic acid, so the nurse-initiated protocol. After reviewing all the previous studies on sepsis and sepsis bundle compliance, some of the researchers found that emergency departments were not complying or using best evidence-based practice, the guidelines set by the SSC, Surviving Sepsis Campaign. So the past studies have shown that the use of the guidelines in hospitals that use the guidelines with evidence-based practice treatment decrease the rate of sepsis and sepsis-related mortality. Despite these studies, it's shown, the research can't talk. The research has shown that it's not being used. Emergency departments aren't being, compliancy remains low. Yeah. Studies also showed a sepsis bundle initiated by the nurse during triage leads to better compliance with the evidence-based practice for patients diagnosed with sepsis. The nurse helped to identify sepsis and notify the provider quicker and initiated the standing orders to start the bundle, which helps the compliance within that first hour. If the patient met 2 or more of the SIRS criteria, like febrile hypothermia, tachycardia, tachypnea, along with the suspected infection, then the nurse would inform the provider and the sepsis alert was issued. The clock would start from this point, and all the times of the sepsis bundle were looked at. The results of the research can be generalized, what am I trying to say? It can be done in other hospitals and other ED settings easily. The results of the study were like other studies that have been done on sepsis bundle and compliance. So the sepsis alert has been shown to decrease administration times. The researchers used the guidelines set by the SSC to develop and implement a sepsis screening measure with the goal of improving identification, communication, and treatment of patients with sepsis. A protocol initiated upon triage in the emergency department served to lower times of administration for IV fluids and antibiotics. The evidence-based practice states that the best approach for sepsis treatment is prompt treatment with fluids and antibiotics. One of the overall themes that came out of the research is that the role of the nurse is crucial, it's really important in quality improvement with the care of these septic patients. Nurses usually lay eyes on the patient first in triage. While in triage, the nurse is checking the vital signs, to check that SIRS criteria. They're using the sepsis screens that are prompted through the EMR. They're recognizing patients with sepsis is difficult, but since they're providing these tools and through education and training, the triage nurse should be able to identify quickly and start treatment on these patients that are screening positive for sepsis. And that's ensuring that they're having the best care, timely care possible. So nursing implications, nurses need to know and use the best evidence-based practice when dealing with sepsis. The purpose in educating nurses regarding sepsis is to help spread awareness of the diagnosis and knowledge of early recognition and prompt treatment with the goal of saving more lives, reducing readmittance and hospital costs. Nurses must keep in mind the high risk of sepsis and the mortality rates associated with it. Assessment is one of the primary tools a nurse can use. It's also one of their primary responsibilities. They're aware of the patient vital signs. They're aware if that patient's screening positive for sepsis, they need to take it seriously. Nursing interventions pertaining to sepsis should be done in a timely manner. We talked about that. The goal is within 1 hour to get all of that bundle done. When a patient screens positive for sepsis, the nurse must talk to the provider and start that bundle. The nurse should draw all the labs, start fluids, give antibiotics, or delegate those tests being done. The nurse must continue to assess the patient's hemodynamic status and intake and output. And here's my references here. And that was my presentation. So we're gonna do the post survey and see how you guys do. Thank you for listening.